Good afternoon. I have another important clinical problem, urinary bladder issues in the elderly. We have in clinics patients with incontinence, difficulty in passing urine, plus urinary tract infection, recurrent urinary tract infection. To introduce the speaker, I will hand over the speaker.
Yeah, good afternoon everybody. Dr. Radhakrishnan is a dedicated and highly regarded associate professor of nephrology at Government Medical College, Trivandrum. She has made significant contributions to the field of nephrology through her extensive research, clinical expertise and commitment to the patient care, and Dr. Radhakrishnan's work focuses on advancing the understanding and treatment of kidney diseases, and she is known for her compassionate approach to patient care. Here, thank you. Over to you.
Thank you, sir, for your kind words. So, in the post-lunch session, I want to sell my talk first. Why this talk? Why should you listen to this? So, do you know that the prevalence of urinary tract infections increases with age to reach about 15 to 35% of community-dwelling elderly people and 22 to 90% of those residing in nursing homes. The key thing is many patients even avoid discussing their problems. Either they're too embarrassed or they have low expectations of treatment, which doesn't say much about our management capabilities. Many physicians unfortunately fail to investigate their patients' urinary problems. So there was this study, known as a surprise study, in which the patients were given a questionnaire and the doctors were also given a questionnaire. And unfortunately, when the patients, around 22% of them said that they have overactive bladder symptoms, only 9% of the physicians actually perceived their patients to be suffering from that. Thankfully, with proper evaluation, much can be done to alleviate lower urinary tract symptoms. And if we don't do it, it might lead to complications like urinary tract infections, urinary retention, and even upper tract kidney damage. So how can we categorize voiding dysfunctions? It can be done in several ways: clinical, urodynamic, pathophysiologic, anatomical. But what I would like to stress is one which will be clinically useful. So basically, you can functionally classify them into two. One could be a failure to store, the second could be a failure to empty. Again, each could be due to because of the bladder or the outlet. Because of the bladder, storage problems can occur either due to overactivity, where the bladder keeps on contracting involuntarily. You can have decreased compliance or a combination of the both. In the outlet, there could be an anatomic incontinence like you have in stress incontinence. We can have a sphincter problem like neurogenic or traumatic, or it could again be a combination. Failure to empty, because of the bladder, it could be hypertonia, atonia, or fibrosis, so that the bladder doesn't contract and empty properly. The outlet may be obstructed because of anatomic reasons like prostate hypertrophy or strictures. It could be functional, which is known as dextrosor sphincter dyssynergia. So how does this present clinically in the elderly? 25 to 50% of patients do not complain of voiding symptoms unless we specifically ask them. So that is an important point, and there could be a considerable diversity in the signs and symptoms. So again, because there are two disorders, they can have two different sort of symptoms. It can be features of decreased bladder contractility, which can be present as hesitancy, dribbling, sense of incomplete emptying, leaking when the intra-abdominal pressure increases, or infrequent voiding. Symptoms of involuntary bladder contractions include urgency, nocturia, and again incontinence. They can have frequent urination, and the patients have to go to the washroom multiple times with an increased urge to urinate, which can be a problem, especially at night. They can have a sudden, strong desire to urinate, and sometimes leading to involuntary leakage before they can reach a washroom. They can have difficulty in emptying the bladder, so that they have to struggle or strain, leading to discomfort and potential urinary tract infections. And as I said, it can lead to complications like chronic urinary tract infections. It can lead to bladder fibrosis, which ultimately leads to the kidney getting damaged and leading to chronic kidney disease. So what are the types of incontinence that we can see? We can have several types. One is the most common stress incontinence, where there is a leakage of urine during physical movements, putting pressure on the bladder, like when they cough, when they sneeze or laugh. This is mainly seen in females because childbirth can injure the structures which support the bladder, especially the pelvic floor, the ligaments. So the bladder will move downward, preventing the sphincter muscles from squeezing as tightly as they should. Next is urge incontinence, again more common in females, where there is unexpected leakage of urine, especially after they have a sudden feeling to urinate and immediately they have leakage also. And this can occur when they sleep, or this can occur when they get some sounds which can stimulate micturition, like the sound of water running. Some drugs and medications can actually worsen this. Next is overactive bladder, where the muscles squeeze without warning. There can be increased frequency, urgency, again incontinence and nocturia. Functional incontinence occurs basically because of physical disability or a lack of access to toilet, or problems in thinking where the patient cannot reach there is a problem in reaching the toilet. For example, somebody has a memory problem like in Alzheimer's, they might be unable to plan a timely trip. Overflow incontinence means there is a large bladder and there is a leakage from a large bladder which is not being emptied properly. Mixed incontinence is a combination. There could be, thankfully incontinence can be sometimes transient, which might pass. It might occur due to an infection or some medication which has been added, or sometimes when they have severe coughing. So what are the quality of life implications? This is especially important because it actually affects the dignity of a person. They can have psychosocial effects leading to embarrassment, anxiety, and then it can even lead to depression. The daily activities get affected because they are not confident to attend some functions, or they are not confident even to go to their jobs. Sleep disruption can occur because of frequent nighttime urination. As I said, this is not a simple thing. It can lead to urinary tract infections, kidney damage, and also affect the quality of life. Sometimes it might end up in some needing some surgical interventions, which, as all you know, might be difficult in an elderly person. Now, how to evaluate these patients? The important thing, especially in geriatrics, is that they have a broad spectrum of underlying mental and physical disabilities. So each patient should be approached on an individual basis. We have to define the severity of comorbidity and comorbid conditions, and also their current functional status. That will actually guide us how much to investigate and how to treat. There could be other diseases and conditions that can induce or aggravate vesicoureteric dysfunction, like neurological disorders, especially cerebrovascular accidents or lumbar disc disorders. In males, there can be benign prostate hypertrophy. We also have to assess the anal sphincter tone, look for saddle anesthesia and bulbocavernous reflex. If these are absent, this indicates that there is an underlying neurological condition. In females, a complete urogynecological examination to rule out pelvic organ prolapse such as cystocele, and assessment of the integrity of pelvic floor muscles is imperative. There are several comorbid conditions which can cause this bladder dysfunction. It could be medical illnesses, neurological and psychiatric illnesses, functional impairments, and also environmental factors, as I said, the accessibility to toilets. Several medications should be in our list, especially alpha-adrenergic agonists, alpha-adrenergic blockers, ACE inhibitors, anticholinergics, antipsychotics, antidepressants, some calcium channel blockers. Even a recent prescription of diuretics can actually precipitate a bladder dysfunction. When we think of diagnosing and managing, it is a multidisciplinary approach because you need collaboration between the physicians, the urologists, and the psychologists to address their complex needs. We can have several diagnostic tools, urodynamic studies, bladder diaries, and imaging techniques, will come to them. And there are several treatment options available. So this was the place where I trained in bladder, this thing. We had a dedicated team just to assess the bladder, and this was the first step of assessment. So the bladder diary, this is a simple tool. There's nothing to be done. They have to just see but it is not nothing to be done, but it is a very easy thing to do. But it requires a little bit of dedication from the patient's side. So you need to measure the urine volume and to record the volume as well as the time of voiding, and whether they had any leakage or not. This is very important because this gives the real world data. Whatever tests you do will not tell you exactly what's happening with the patient. It cannot mimic real world, whereas this is what is happening to the patient. So this looks a very simple tool, but is actually very useful when you evaluate the bladder. Next is this. This is a Bristol stool scale. Again, a very simple thing. You just give this chart to the patient and ask them to grade stools over the past 1 week. So based on types like there are type 1 to 7. Type 1 is separate hard lumps like nuts, and type 7 is watery with no solid pieces at all. And around type 3, 4 and 5 can be considered as normal. So when it is said that if you are going to major in bladder, that means if you are going to focus on bladder management, you have to minor in bowel as well. Unless you treat constipation, the bladder issue is never going to go away. An X-ray KUB might help us to diagnose constipation. It can show an impacted fecal mass. Next, come to the proper evaluation part. One is the uroflowmetry. So uroflowmetry is again a very simple in-clinic test. You have you have this is the whole machine. This is the whole equipment actually, and this is connected to this reader. So basically, you have a commode-like thing where the patient can sit if it's a female, or he can stand and pee, and this records the volume as well as the force by which this comes, the urine is flowing. So based on that, we can have different patterns. So this is a normal pattern. You can see a normal bell-shaped pattern. This is how normal people should void. These are the abnormal patterns. So here you can see the flow rate is not high, it is very less, and it is prolonged for some time and then it ends. So this is a typical obstructive pattern. In the next pattern, again this is similar, but you will have some peaks and troughs. So this is a dextrosor impairment where the dextrosor muscle is not contracting properly, hence the flow is also poor. This is a Valsalva voiding pattern. Here what happens is, there is a dextrosor sphincter. There are areas of some reasonable flow, then it comes down, again there is some flow, this is because it is not the bladder muscles which is voiding, it is the patient is actually using his abdominal muscles to void. So whenever he can contract his abdominal muscles, you get some flow. When it relaxes, the flow comes down. So this goes on. This is what is called a superflow pattern. This is typical of an urge incontinence, where the patient voids very fast and it voids over a very short period of time. So this is typical of an urge incontinence, superflow pattern. To have a proper uroflowmetry, the voided volume should be at least 150 ml. If it is less, it's not reliable. Next comes post-void residue. You can use a standard ultrasound, or you can use this very small handy ultrasound machine which can measure the post-void volume. You ask them to void, or you ask them to do the uroflow, and just after that, you just put it in the suprapubic area and measure. It will tell you the volume. More than 200 is, up to 100 can be considered as normal in the elderly. More than 200 is inadequate emptying, and more than 300 is definitely urinary retention. Urodynamics is more a formal test. It requires a little bit of dedicated equipment and a dedicated personnel. It's not a very easy test to do in a clinic unless you have a setup for this. So in urodynamics, what happens is you have the pressure transducers in the bladder, pressure and flow transducers, as well as in the rectum. And you will record the dextrosor pressures, the abdominal pressures, and find that curve. We can actually get different types of curves which will tell us what is wrong with the bladder. So now we have diagnosed, we know that these are the symptoms, this is how the bladder diarrhea looks like. We have done a uroflow and we have done a urodynamics whenever it is indicated. Urodynamics is not done very routinely in all the patients because it's a invasive test. You need a bladder catheter as well as a rectal catheter to do it. So it is not done routinely, it's done only when really indicated. So now what are our management goals? We want to give relief of symptoms. We want to prevent and treat urinary tract infections, and we want to ensure that the bladder empties completely. So our treatment options include behavioral, pharmacological, as well as surgical. So let's go to the behavioral management. Sedentary lifestyle and obesity is known to increase the bladder dysfunction. So physical activity should be encouraged, weight reduction should be encouraged, and if you can achieve at least 5 to 10% of weight loss, it can significantly improve the symptoms of incontinence. Dietary habits, especially high caffeine and alcohol intake, should be discouraged because they all irritate the bladder and contribute to bladder dysfunction. Regular fiber intake and good fluid intake, we know that can relieve constipation. To minimize nocturnal polyuria, we can confine most of the fluid intake to the morning or early afternoon and ask them to void before going to the bed. And if they are smokers, they should be encouraged to stop. Bladder training techniques will improve the bladder control and improve the voiding patterns. we can actually gradually increase the time between voids. Like if the patient is voiding like every 30 minutes, we can ask them to try to hold for another 10 minutes, then slowly increase the interval to an interval of around 1.5 to 2 hours. We can also ask them to do scheduled voiding. Some patients may not be voiding properly. They might be voiding once and then another after 4-5 hours. So to establish a regular voiding pattern and to prevent overfilling, we can set regular intervals for bathroom visits and make sure that they go at that times. We have to balance fluid intake and reduce the bladder overactivity. So it should be again individual based. Behavioral modifications will like managing stress, anxiety can also affect bladder function. So every 2 to 4 hours they should be voiding and use a double voiding technique. Double voiding technique is nothing but you void and you stand up and immediately sit and void again. So whatever urine is left behind, some patients will have some left behind urine, that also will get passed down. So that is 2 micturations will empty the bladder more effectively. In a patient with hypotonic or atonic bladder where the bladder contraction is not good, they can actually augment it by pressing the lower abdomen. That is known as a Creed's maneuver. Pelvic floor exercises, especially Kegel's exercise, will strengthen the pubococcygis muscle. They are helpful in stress and incontinence. You can actually insert a finger into the vagina or rectum and they are asked to contract as if holding back urine. Medical management, the main drugs that we use is anticholinergic because they reduce the extrusor overactivity by blocking the acetylcholine receptors. The drugs include oxybutynin, tolterodine, solifenacin. Oxybutynin is very commonly used and usually started in a dose of 5 mg. And they are effective in reducing urinary urgency and frequency. But again, the main problem is most of the patients that you start on this drug usually stops the drug after some time because of side effects, especially dry mouth, constipation, blurred vision, somnolence, dizziness, etc. The newer generation drugs like solifenacin and darifenacin have lesser side effects compared to oxybutynin. Beta-3 agonist is a new group of drugs which has recently come in the market in the last couple of years. The drug which is available is mirabegron. Again, they can relax the bladder muscle and improve the capacity without much side effects. But the side effect to be aware of is headache and hypertension. Dextrosa sphincter dyssynergia, you can actually relax the sphincter by using alpha blockers. All these therapies should be adjusted properly. Imipramine is another drug which can also reduce the overactive bladder symptoms by improving the bladder capacity. Clean intermittent catheterization should be done when nothing works. If the patient is not able to empty the bladder, if there are recurrent UTIs, it's best to put them in a clean intermittent catheterization. But again, it should be done properly, otherwise it can cause bladder irritation and urinary tract infections. And patient should be, and the bystanders or the family members should be trained properly. Surgical treatments is usually not preferred in elderly because of all the comorbidities and the morbidity associated with the surgery itself. In future, we might have novel therapeutic approaches. So my take-home message is bladder evaluation should be done properly and we should not just say it's a bladder dysfunction in the elderly. We should evaluate, find out the cause and treat it so they can live a life of dignity. Thank you.
Thank you very much, Dr. Radhika, for having given us an elaborate overview on a problem among the elderly which can be quite distressing and has social as well as medical implications. An important cause of chronic kidney disease, especially among males, is bladder outlet obstruction. And we have had situations wherein patients have come to the casualty saying with a creatinine of 10 and urea of maybe 200. And the nephrologists get called for dialysis, and it only takes a moment to realize that when you put a hand on the lower abdomen, you find that the bladder is all distended. You just evacuate it slowly, that's important. And then you find that over the course of time, the creatinine comes down to a pretty low value, if not normal. So implications are wide-ranging. And thank you very much, Dr. Radhika, for having given a very elaborate description on that. The topic is now open for discussion. Post-lunch sedation.
If there are no more questions, we will wind up the session.
Right.
Thank you, ma'am.
Thank you.
And thank you, chairpersons.